Hello, everybody. Welcome to another episode of A Manic Odyssey. We continue our journey talking to these incredible DBT therapists. Today, I have Nora Josephson, who is the Clinical Operations Director at the DBT Center of Orange County. Hello, Nora.
Hello.
Thank you so much for coming on. I so appreciate it. I think you understand that what I'm trying to do is get the word out about DBT. I'm trying to meet with as many DBT therapists that are willing to meet with me and just talk about your experience, what it has been like working in the DBT field, what brought you to DBT. So let's just start with who are you and what do you do?
You already introduced me, Nora Josephson. I'm the Clinical Operations Director at DBT Center of Orange County. I wear many hats, but I work closely with our clinical director, Dr. Sarah Linden, to work on like clinical processes, training. And then for my particular role, I kind of bridge the gap between our admin team and clinical team. So I do a lot of the policies and procedures and kind of organizational stuff on the back end as well.
Amazing, amazing. And in your undergrad, were you like, hey, I'm definitely going to go get my master's and do DBT, or what? Where was that turning point for you?
No, I was always interested in therapy, being some kind of a therapist, and that was probably since high school. In undergrad, I did major in psych, but I thought I originally wanted to work with kids, and then quickly realized I was worried I would take them all home with me. So I was like, no, I need to work with adults,
Yes.
and primarily I have worked with adults. I also work with teens. Um, After school, going into my master's program, I did learn a little bit about DBT. They don't have much in the master's programs
Mm,
about DBT. I hope that's changing.
yeah,
Um, it was a very small paragraph in like our psych theory class.
sure.
Um, did learn a lot about CBT, and I'm also a yoga instructor. So I have that background with mindfulness, and that's what really got me into being interested in DBT in my first master's practicum and then internship. I was able to do DBT skills groups at that time. So I
Mm,
learned the modules and the skills in the modules: mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. And I was able to just kind of dive in and facilitate those groups and learn the skills alongside the clients as I went. And I really loved teaching the groups. I loved learning the skills myself, applying them myself. So when I moved back I grew up in California, but I was in Colorado for 10 years, and then I moved back in 2017, and I found DBT Center of Orange County, and I've
awesome.
been at here since.
Awesome. Yes, I was going to say, I looked at your bio. You wear many hats. You are doing lots of different things, whether it's overseeing the mindfulness practicum and the mindfulness leaders at DBT Center of Orange County. I wanted to ask you, how long I think I read that you said you've been doing yoga since your master's program. Is that what you said?
Since undergrad, my senior year of undergrad, I started the training, so I think since 2010.
Yes, so it's just such a natural pairing with what DBT brings to the table. What do you feel kind of gives because in my mind, like coming into it with that mindfulness background, a yoga especially, I'm just getting into yoga. Thanks, of course, to the DBT Center of Orange County. We had that. Oh my goodness, I'm forgetting my instructor's name. She was so lovely.
Mm.
Um, but it was just so profound, and I was like, I could do this on my own. Like I should do this, more often.
Mhm.
Um, what is kind of the process of being a DBT therapist when your background is so heavily involved in mindfulness? Like, do you feel like you kind of have a leg up on the understanding of the modules, or do you feel like it's just, another one of the strengths you bring to the table?
I did think that I had a deeper understanding than like the average clinician using learning DBT, because I already had that mindfulness component within my yoga practice.
Yeah.
I already understood how difficult it can be, right? To stay present, to feel all the physical sensations, all of the pleasant and unpleasant emotions. Yoga gives you that. You have to push through. You don't want to do yoga every day or, be at every class, but you push yourself in that way. So I had my own personal experience with that.
Mm,
And then as a DBT clinician, I was definitely more easily able to facilitate mindfulness practices. I could even lead them through a short, yoga flow as part of it.
Yeah.
And something that we really try to teach in our DBT programs is mindfulness isn't just meditation. It doesn't have to be one thing. So we
Yes.
really try to provide a wide array of what mindfulness can look like in your life.
Yeah.
So my yoga background, I think, helped me bring even more to it.
Totally, totally. So I got to talk to, of course, Sarah before, Dr. Linden before, and she's just a well of information. So I got a lot of fun, important context for just the way the DPT Center operates and the way that just you as a team are so cohesive. We talked a lot about the oh my goodness, what is it called when you guys come together as a
Oh,
team?
clinical consultation team.
Clinical consultation team. Yeah. So I'd love to just keep going into that and dig a little deeper and just hear your experience coming in with your mindfulness background, how that teamwork dynamic continues to give DBT kind of what we were talking about was a little bit of a buffer against burnout.
Mhm, mhm. Um, Clinical consult can be very similar to other group supervisions, and I think any young clinician out there has a lot of supervision, individual supervision, group supervision.
Yeah.
However, DBT has so much more accountability for the clinicians in clinical consults,
Mm,
and it's very structured. So, um, I love that we usually start with a mindfulness practice and we're really applying DBT to ourselves. I definitely think it helps reduce burnout. We do work with challenging clients and clients who have a lot of challenges themselves, a lot
mhm.
of, trauma, a lot of painful behaviors, painful relationships. And they are challenging to work with sometimes.
Yeah.
And we could definitely, have vicarious trauma through working with them. So having that accountability that we can bring them to team, we can talk about our own experience with working with them and how we're that community of therapists treating a community of clients and we're not in it alone.
Yeah.
And one thing that I was writing down, exploring some of these questions of what we're talking about today, is
Yeah.
that DBT is a principle driven treatment, not a protocol treatment. So it's
Mhm.
not a protocol where it's, oh, this is what you do, and then this is what you do. It
Yeah.
really is flexible. You shift with the clients using the principles of DBT. So there isn't just one thing you do when something arises. And
Yeah.
that clinical consultation really supports you with is we don't have to know everything. We don't have to be perfect with exactly knowing what to do next with the client because it's not protocol based. You don't know.
Yeah.
And so having the other clinicians there to utilize for brainstorming or what do you think would be effective is just magical. It's very helpful.
Yeah. It's so interesting. You're describing something that I think probably would benefit just the entire psychological mental health community. It seems like, especially the way that it's portrayed in the media, it's kind of a one man, one woman show. Like they're, you come to the office one on one, in most clinical or most like stereotypical experiences coming to therapy. But the DBT uh, model is very team oriented, like you're describing. And I'm wondering, in just your experience, I'm sure you rub shoulders up against different clinicians at different modes of treatment. Why isn't this a more common thing in clinical circles? Why is it that we kind of hear these stories of undergrad, or I'm sorry, master's program students getting burned out so quickly because they don't feel supported because they
Mhm.
are having to put in so many hours at like $25 an hour in Southern California? So, in your opinion, again, no wrong answers here. Why is that not more common?
I think it's challenging to find the time. I think we're always pulled into different directions as clinicians. Generally, the patient work, the client work is where a clinician wants to be. So the documentation work, the collaboration of care kind of comes on the back burner.
Mm,
And that's part of it, I think, is when you need support, when you need peer consultation, when you need further supervision, it's really hard to advocate for that and to make the time and the space.
yeah,
And as a DBT clinician, it's part of the therapy. You have to have it. The structure is there.
yeah,
And even though we may not want to show up to clinical consultation every week, we're tired, we're humans, we have other things to do. You
yeah,
have to. It's part of the treatment. And it's great that we have that structure because you do need that time to explore, to think which, where is my burnout? What's happening with my work with these clients? Where do I need support? And we're asking ourselves those questions each week and having that mindful awareness of where we could benefit from that.
Yeah, and Dr. Linden said that when somebody comes into that environment, that you guys are all equal. That anybody who is coming through, whether it's a clinician who's been there 5 years, somebody who's just coming into their program, you are treated and respected in a way where you have something of value to bring to the team. Has that been your experience as well?
Yes, and, although Sarah, you're going to meet Karen and myself are speaking, I would say more often, we don't want to be, and we really try to include other voices and encourage others to speak up about it because it really is coming back to that humanness and recognizing that we're all human, we're all fallible, we all make mistakes, even as therapists, even as clinicians,
Yeah.
and how do we all support each other in that and see each other in that?
Yeah, I love that. I love that. Okay, so as I'm not sure if Sarah shared this with you, but I got my treatment through DPT Center of Orange County, so it's a very special place in my heart. Obviously, I think that all the programs are amazing, but of course, I have a little bit of a bias in my current personal experience. And I got diagnosed with borderline personality disorder, which for me that was a pivotal turning point to actually get the correct treatment because I had been in talk
Mhm.
therapy and psychodynamic therapy since I was 11, and when I walked into the DBT world, I was like, "Oh, this is both heady and, logical while also being incredibly grounded and spiritual and also very
Mhm.
practical." So it was like all of the things my brain didn't know I needed at the exact same time. And in my experience, since that diagnosis, I've met a slew of other people who have had similar experiences where it's kind of a light bulb moment and then they start getting the treatment that they desire and they didn't realize that they could have a life worth living. They didn't even know like in my case, I didn't even know it was possible to get to a place where I was prioritizing mindfulness and being able to tolerate such difficult dysregulation throughout just interpersonal or other social situations. In your experience, because you've worked both with teenagers, you said, and adults,
Mhm.
why is it that the general population seems to have a bit of an issue with understanding what dysregulation looks like in somebody else, especially with such a kind of not controversial but stigmatized diagnosis as like the borderlines, the bipolars? Um, yeah,
I think there is still a stigma related to the borderline personality disorder diagnosis and bipolar diagnosis, and often those are misdiagnosed with each other.
yep,
Um, I think finding the right treatment is so important. So that's really my view of it is, in our initial intake, kind of doing a whole background biopsychosocial, um, figuring out we will diagnose and what is the diagnosis. We don't need to focus on the diagnosis.
mhm,
If it is beneficial to the client, finally having a name for what they're experiencing and the research behind it and knowing that they're in the right place. I think
yeah,
we will use that as a resource. But
mhm,
once I know they're in the right place, DBT is a fit for you. DBT is going to help with that emotion dysregulation, then I kind of let it fall into the background and again fall into the treatment and really have that structure of doing diary cards, doing behavior chains, figuring out targets to decrease and increase, um, being able to come back to the skills to build that life worth living, to live life more effectively, that there's nothing wrong with the person. And I love teaching that it's a skills deficit model. You
mhm,
haven't been given the skills that you need to live this life effectively. And this is
yes,
just about learning the skills so you can manage life effectively and build that life worth living. And I see it as a very human experience because I don't know any human that doesn't have emotion dysregulation, including myself,
yeah.
even though I may not have that diagnosis.
Totally. I was That's beautiful. Thank you for sharing that. I agree, and Dr. London echoed that, that if the diagnosis is helpful, cool, we'll camp out there, we'll figure out how to get you to a place where you want to be living life once again, if that's the mode we need, but it's not necessarily the end all be all. We can focus on the skills. It's literally what you were just talking about, right? It's not a protocol, it's a principles thing. So Yes, if the
Mhm.
principle of DBT works with you having a diagnosis, cool, we'll go that route. But if the principles don't, we still have plenty of other tools in our tool belt. Um,
Mhm.
when it comes to the the skills that people lack, right? In your experience, do you find that people who internalize the DBT courses and internalize the DBT program end up finding that they have a lot of relationships in their life that they can no longer keep simply because those people are not
Mhm.
willing to learn the skills that they just learned?
They definitely experience challenges with that. They're like,
Yeah.
"Wait, I'm changing, I'm doing the work," and maybe these relationships were the ones that told them they needed to do the work. And now you're not being effective, right? They're
Yeah.
experiencing that with their partners, with their parents, with their
Yeah.
siblings, with their friends. You're not being skillful, you're not doing the work. Why am I doing all of this?
Yeah.
Absolutely. And I think with the validation, self-validation and validation of others, with the compassion, self-compassion and compassion towards others,
Yeah.
you can realize how hard it is to change, how hard it is to take in the skills, how hard it is to be skillful.
Yeah.
Um, it's a wonderful part of DBT that we don't have to be perfect clinicians, that we can be humans ourselves. And we'll share, especially in like a group setting, examples of when we haven't used the skills and
Yeah.
that we reflect on afterwards and we're like, this would have been a great time to use the stop skill
Yeah.
or to um, go and use tip the temperature before coming back and presenting a dear man. And we don't, because we're human and we all get emotionally dysregulated, swept away in emotion mind sometimes. And it's about coming back to the skills, trying to be as effective as possible. Um, we do talk about what is like an interfering relationship and then
Hmm.
what's a destructive relationship, and really sussing out, is this a relationship you're willing and able to work on and
Hmm.
try to be more effective together, or
Yeah.
is this truly destructive and it does need to end, and how can you do that in a safe way?
Yeah.
I will say for the most part, once they're able to rely on themselves, use their skills, um, they might set better boundaries or, more effective boundaries and
Yeah.
limits, and they're able to navigate those relationships. They might just look differently. And
Yeah.
others really do learn from their modeled behavior and
Yes.
maybe even get interest in learning the skills for themselves. We do hold a loved ones workshop where parents, partners, siblings can learn the same skills that they're learning in their treatment.
Yeah.
Um, it's similar to Family Connections, which is a free resource for those who have loved ones with borderline personality disorder or emotion dysregulation.
Oh,
It's
cool. I don't
similar
think
to
I'm not sure if I knew about that. Wait, tell me more about that. What is Family Connections?
Family Connections. Is we have a little bit more information on our website, but it's through, real quick, let me see. It's through, I'm blanking on the name right now. Why? Okay. NEABPD, National Education Alliance for Borderline Personality Disorder.
Cool.
And so they don't necessarily have the need to have the diagnosis with BPD. It can be more broad, like we're going with emotion dysregulation. But if they have somebody in their lives, a partner, daughter, anyone where they don't know how to respond to them. They get so emotionally dysregulated and they don't know what to do themselves. And they're
Yeah.
in that system, similar to if you're in a system with an addict and you don't know how to respond to the addict, you don't know how to keep them safe when they're engaging in substance use. It's kind of similar to that. When they're emotionally dysregulated, what do? I try to
Hmm.
help them and they just keep getting bigger.
Yeah.
It's really how can they understand that and what's going on while also using the skills on themselves, because they can't force another person to change. They really need to come to that on their own. They need to come to their willingness to be
Yeah.
uncomfortable with the change and to learn the skills, and they can't force that to happen in their timeline.
Yeah. Yeah, that makes perfect sense. And it kind of like aligns with what we're with the principle of, the loving kindness meditation, right? If
Mhm.
there are people in your life who, for whatever reason, right, it is difficult to learn these skills. It is difficult to accept. I find that the most difficult part is accepting that you have skills to learn. Because it could be hard to learn that you've been invalidating someone, that you've been judgmental, that you've been putting them in, that they've been feeling, certain ways from you. So that's painful to be like, to
It
accept
is.
the fact that, oh man, I've been hurting somebody that I love, that I say I love and I care about.
Mhm.
And then of course, I think the necessary next step is, am I willing to, do I have a willingness to want to do this work? And what I love about the loving kindness meditation is it kind of takes the impetus off of you and doesn't make you responsible for other people's behaviors. It just says, hey, here I am. I'm going to do what I can to just let them know that my thoughts are my own, and I'm sending you all of the loving kindness that I want for myself. Because
Mhm.
essentially, right, that is what most of us want. Is once we get that inner peace, we're not like, finally, it's mine. Nobody gets it. Like it's like, oh, does everybody else know about this? Like, are you aware of this mode that, we could all be here together and it would be really lovely? We wouldn't have to be so mean all the time.
Yeah.
I
And
love
that
it.
helps, like, coming back to we have the DBT assumptions that we're
Yes.
all doing the best we can,
Yeah.
and we need to improve. And
Yes.
I was thinking as you were talking too about when we present in invalidation, and that often we all invalidate, and it's not purposeful, right? We can
Yeah.
invalidate by accident by just
Yeah.
saying things, that we don't realize how it impacts somebody. And we can take accountability for that, and that's painful, that's hurtful,
Yeah.
that's hard to move through. How can we improve on being more understanding, more validating, stepping into that person's shoes,
Yeah,
etc.
absolutely, absolutely. Okay, well, you saw the questions ahead of time, so I'm going to ask you
Mhm.
a spicy question, which is, do you have thoughts, opinions, or feelings about the rapid increase in online TikTok, Instagram, Snapchat, pop culture, basically, or pop psych therapists that are popping up everywhere and have like, the how to, this is what it looks like, giving people language that is very important, but maybe not the whole complete context.
Yes, I think it's dialectical. I love seeing it. We try to have a presence as much as we can. I just turned 36, so I'm not the youngest clinician, and I don't feel like I get the whole TikTok world
Sure.
completely.
Yeah.
And we've been trying to put out our own like cute DBT skills reels, and trying to get the information out there. In one sense, why it's dialectical, I think it's wonderful because for especially younger clientele,
Mhm.
I don't know, teens,
Yeah.
young 20s, they are on TikTok a lot. They are
Yeah.
utilizing social media a lot, and that gives them, I think, more effective things to look at and to listen to and to digest.
Yeah.
Um, on the other side, it's harmful, I think, to stop there
Yeah.
and to only experience self-help or therapy through social media. I think that can be harmful. I remember when the kind of talk therapy apps and find a therapist through an app kind of started to come out probably over 5 years ago now. I don't know when that
Yeah.
exactly occurred,
Yeah.
and I was worried about that. We do have phone coaching as a part of DBT. We can text and call our clients, and they can call us. Um, and that's not the only form of therapy. They still come into the therapy room,
Yeah.
whether it's over Zoom or in person, they still have that individual therapy component.
Yeah.
I think having it be smaller and just digested through social media or even just a therapist through text, um, doesn't experience the whole healing that can come through a therapeutic relationship, which a
Yeah.
lot of research shares that's where healing takes place. It's not just through the skills, it's not just through the principles, but it is through that rapport and that relationship with
Totally.
their therapist. And I don't think that can be achieved through those mediums.
Yeah. No, that makes perfect sense. I feel similarly. It is very dialectical because on the one hand, yes, it's so great to have like these high-minded, very often hard to grasp concepts distilled down into 30 seconds or a minute and 30 seconds or 5 minutes or whatever it may be. And at the same time, I get discouraged when I see people then take that information and apply it in relationships kind of ineffectively and then be surprised when they're dysregulated because I just called my boyfriend a narcissist. I just learned what a narcissist is. He's a narcissist, but now he's really mad and I don't understand what's going on here.
Mhm, mhm.
Like I
Yeah,
think
and I
for me,
wouldn't want them to give up after that, right? Like, "Oh, it
right.
didn't work. I used this DBT skill or I used this what I thought it was and it didn't work. And to
Yeah.
stop there, to feel deflated or to feel hopeless about it, that would worry me too.
Yes, and I mean, what's what I'm discovering just through like comments sections and interactions online is that there is kind of this now like kind of new generation of educated individuals where they at least have a basic understanding of kind of like common psychological ideas such as boundaries. Um, like you're saying though, the next step though is then to understand what boundaries mean for you, because boundaries aren't just I don't like that so therefore I'm not going to do it and that's my boundary, or like I shouldn't have to do this and therefore that's my boundary. the,
Right.
the next level, like, I catch myself all the time trying to like butt out of it or should out of it, ought to out of it. And when I catch myself doing that, I go, okay, there's an and here somewhere. So here are all these things that I'm realizing, and I don't think I'm grasping it completely. And the thing is, like, I consider myself deeply lucky because I just happen to have a partner who's equally interested in evolving and growing together. And someone who recognizes that she has her own stuff to work through, and so like she's not constantly pointing the finger at me. It's what are we doing here, like what could we be doing together. So I think one of the most important books we read was Nonviolent Communication. It was just so incredibly insightful. It's just the way my words were being interpreted, the way that what we're saying was being heard. And then I read High Conflict Couples by Alan Frazzetti. Is that his name?
Rossetti.
Frazzetti. That was also incredible because that book is literally not just about, but primarily about validation. And like you
Mhm.
don't even realize when you're invalidating yourself in an argument or in a conversation, and then you're not paying attention to your body. It's like my heart rate's elevated. Why is my heart rate elevated? Well, probably because I just invalidated myself and I'm on the defense. So it's like all of these dialectical waves overlapping into one another that I really just love. I think the world would really benefit from just why we're doing this, just knowing a little more about the therapeutic relationship, especially with these DBT uh, modes of therapy. And then, so my follow up to all of that is there in the psychological world? I know that there's a lot of continued education, right? You guys go and get certified and continue certifications. Love that. Think it's the way it should be. In those recertification processes, is there any incentive for practicing clinicians across the spectrum of whatever modes they use therapy to try and, for like a trial period, do a different mode of therapy? So, like, so for example, for you guys, right, it might be, hey, this month we got certified in this new psychodynamic approach. We're going to now implement this into some of our training for 1 month or whatever, and see like how it flows with us. And then vice versa, like, hey, we're a psychodynamic clinic. We don't use DBT skills, but we're going to start trying to use them after this little training. Is that something that's happening behind the scenes, or are all those worlds kind of schools of thought disconnected?
They're not disconnected. I think more often you don't change to a completely different theoretical orientation, and it's more trainings kind of related,
Hmm.
or what could be working with the same population.
Yeah.
Somebody absolutely could completely change their theoretical orientation halfway through their career, but it wouldn't really be, I don't think, as much bouncing back and forth.
Hmm.
You could have an integrative approach. They used to
Hmm.
call it an eclectic approach. I'm pretty sure that's frowned upon now.
I had a therapist
That's kind
that
of an
said he was
older
eclectic.
term. So
Yes.
it's more of an integrative approach
Yeah.
because primarily at DBT Center, we do adherent DBT. With some clients, we might do DBT light is what we call it. And you could incorporate different strategies. ACT is another third wave of CBT incorporating mindfulness and acceptance. So we do
Hmm.
use some ACT ideas. It's very similar to DBT though. So I
Yeah.
think it's pretty easily incorporated. And then once the clients move to stage 2 treatment, you might pull in trauma work. So a lot
Yeah.
of clinicians also are trained in EMDR or prolonged exposure, which is really working with more that trauma.
Yeah.
Um, I think you can pull from different modalities and different trainings. I have done an Alan Frazzetti training on like high conflict couple work.
You met
Um,
him?
so Yes, I
Oh
have
my
met
gosh, that's so cool. That's so
him.
cool.
He is amazing, he really is, and that's DBT adjacent. I mean, it is doing
Yeah,
DBT, but it is primarily helping me with that specialization of more couples work and systems and family systems.
yeah,
Um, so you can have more an integrative approach. We don't do that as much because we're doing it here in DBT generally, and that's who comes to find us.
yeah.
But for other clinicians who are more in private practice, could pull on many modalities and really what fits with the client and what they're showing up with and what could they benefit from as well.
Yeah, I love that. I love that. What really makes me like, oh, that's so great, is that DBT for the most part seems to be open to feedback, not only just from the person that they're talking to, but like you're saying, in these team meetings that you have where you're,
Yeah.
everybody's human,
Mhm.
everybody needs feedback every now and again for whatever it may be. Um, with other modes of therapy, right? Is there, how do I say this? Or I guess, wait, here's a different way to say this. Why isn't all therapy a process or a principles based practice instead of a process-based practice? Because
Mhm.
I know that there's plenty of evidence for the psychodynamic approach and for CBT. I'm well aware that they have their own foundation to stand on. And when I talk to people about disappointing experiences in therapy, usually it's revolving around a therapist who was either not ill-equipped or didn't have their own support system, or just
Mhm.
wasn't a good fit, which again, that's
Mhm.
very
Mhm.
common. So it's just in your personal experience, why is that? Why is it not all a principles based
Well, in my
practice?
personal experience, I think that is more the old school way of doing therapy, that the therapist is the expert. The therapist did
Mm,
used to give advice.
mhm.
And especially with DBT, we say we are not the expert. We might have expert skills and knowledge and training, but
Yeah,
the client is the expert on themselves and their life and what their values might be different than mine. Their life worth living goals absolutely are going to be different than mine.
yeah,
So it's really how do they get to live their values, to reach their life worth living goals, and they're the expert, and I'm supporting them in reaching those.
yeah,
Um, Other therapies, I think, still are holding on to basis of, years and years ago of they are the expert and they might give advice to the client and it might just not be a fit.
yeah,
So that's why it is more principle driven. I think there are benefits to protocol driven treatments. And I think it just depends on the setting.
yeah,
In community mental health, maybe when people have less resources and things like that, I think there are protocol driven treatments so that the clinicians, possibly trainees who are going in, can easily provide effective evidence-based treatment, and it
yeah,
is protocol driven. They know exactly what to say, exactly what to do, exactly what to use, and I
yeah.
think that can be effective, and it is heartbreaking when it is a poor fit and they don't know how to pivot or get the person the resources that they need.
Sure. Yeah, that makes perfect sense. Okay, that makes perfect sense. I'm thinking also to the idea like that the therapist as the expert and the idea of the principles versus procedures. Is that the word we've been using? Procedures? Is that the word?
Um, Principles versus protocol based.
Thank you. I was like, I knew it was a P, but I didn't know what it was. Principles versus protocols. I in psychodynamic approaches more so than maybe behavioral centered approaches. um, do those, because what I've read more so is that if there's an issue, maybe it's because you as the therapist aren't expert enough, or like something is wrong with you as the therapist in some of those approaches. What I'm hearing you say with DBT is that that's not really the case, that it's nobody's fault. There isn't like blame that needs to be passed, or there isn't like accountability for what you're doing incorrectly. It's more come together, what does the client needs, they're the expert, let's come with them, let's come alongside them, versus let's come at them with this information. Is that true to your experience?
Yes, and you can't know everything. I don't think I
Yeah.
know
What?
I don't think I
No.
know anything I don't think I know everything about myself, let
Mhm.
alone the client that I've known for what, months
Yeah.
or,
Yeah.
weeks possibly.
Yes.
So it's that continued curiosity, non-judgment, and coming into the room to explore that, to be more curious, to be non-judgmental as you explore it together.
Yeah. I love that. I love that. Of course, there are so many examples in media. Dr. Linden and I were talking about how silly the therapist is represented usually on screen. Normally
Mhm.
because they're just like a little morally corrupt at some point. And we're like, oh, I guess all therapists like maybe want to like take their client out to dinner and like have kids. Like it is what it is. I don't know how to go
That
about that.
pisses me off so much. I
I
know. Why is
know.
that still out there? I'm like, does the media know how illegal that is?
I don't think that whoever is like the consult for therapists in the media, I think that they're still would call themselves eclectic based on what you've said.
Yeah.
But yeah, that cracks me up. Well, let me see here. Do you have a favorite DBT related book other than Alan Frazzetti? Because we've already said that one. And if
I have
not
read
DBT,
High Conflict Couple. What we call is like the Bible or the big book is the older cognitive behavioral treatment of borderline personality disorder
uh-huh,
by Dr. Marshall Linehan.
uh-huh.
I also think the DBT Skills Training Manual, second edition by Dr. Marshall Linehan is really helpful in leading groups and really knowing the skills and knowing how to present the skills, different examples. It's very informative. And it's kind of DBT adjacent, but something that we present in some of our groups is Shauna Shapiro's TED Talk
Hmm.
of what you practice
Yes,
stronger. And she
yes.
came out with a book, Good Morning, I Love You.
Huh.
And it says, it just is more on that mindfulness. What you practice goes stronger, kind of meeting yourself where you're at. I think it has a lot of validation in DBT adjacent again skills, and I
Yeah.
love that one too because I just love
Yes. I love that title. Good morning, I love you. That's
Mhm.
just lovely. That's just lovely. Well, I have a couple other questions to you, and then I'm going to throw a curveball at you. So let me know if you're ready for it.
Okay.
We just talked about TV shows and movies. Clearly, the Mr. Obviously, my favorite TV show is Hannibal, and that's not a representation of most psychiatrists and therapists. I certainly hope not. But what about you? Do you have a favorite TV show that maybe doesn't have to be related to DBT, but you feel like this is what I come back to? This is like my safe place, or this is like, oh, a show that I watch often.
Well, when I read your question about that, like related to DBT, not a TV show, but the wonderful DBT Are You YouTube videos are amazing. They're
What are
little
those?
cartoons about the DBT skills. So DBT Are You, and it's from Rutgers University. And many of them have been created in recent years because over the pandemic, a lot of college campuses couldn't meet for groups,
Mm,
but they were sharing that really the research was showing that even with these videos and learning the skills through these YouTube videos was beneficial and did have positive outcomes, just like as if they were in a DBT skills group. So we love using those in our groups. We love that of just, some of our clients just teach their family and their friends. I'll send it to my friends if they're like, oh, what should I do when I'm stressed out? I'm like, here, learn the
here.
take skill. So I love the DBTRU videos. Um, I don't know that there's any, yeah, it says DBT or unrelated to DBT. I mean, I I guess because I work with clients and with real life problems and things like that, I'm definitely the one who wants to shut off my brain at the end of the day. So I love cheesy rom-coms or fantasy. I love a good trilogy, so any of
Ooh,
the Jurassic Park, Star Wars, Star Trek,
yeah.
all of that.
Oh
I'll
yeah.
get to really cheesy ones like Vampire Diaries, and my husband,
Oh, say Vampire
will
Diaries.
be made to watch it with me.
That's how I tell
Yeah.
people how to spell my name. I'll be like, "Have you watched Vampire Diaries?" Like, yeah, I'm like, it's spelled the exact same way as Stefan Salvatore. It's the
Oh,
exact same
yes,
spelling.
yes.
So I
No,
totally
that's my cheesiness.
not cheesy. That makes perfect sense. I have a friend who used to be a social worker, and she's still a social worker. She just is a mom right now. Anyway,
Mhm.
and she would come home and watch. They'd watch like Lego Masters, and they'd watch like cook shows because she has to deal with just that shit all
Yeah,
day long. You got to be able to take a
you
break
just
and
wanna
unplug a little.
relax, yeah.
100%. So one thing that I totally swung and missed with Sarah is that Dr. Linden is that I forgot to ask her if she had any questions for me. So I'm gonna have to bring her back on again and do that again. So I'm gonna turn the table real quick before I get to my last question and just hey, do you have any questions for me? If you want to put on your therapist hat real quick, I'm open to whatever.
Well, I guess my question for you is just having been through a DBT program yourself, what was, I guess, like the most amazing part for you? And then what is our area for growth, even with your own DBT treatment, and what you think could be beneficial to for us to continue to grow in that?
Great question. I think what made it fantastic was at first very practical, right? You could work with single case agreements, right? That was the only clinic I could find in my area that could accept single case agreements with my insurance. So that was huge. So strong
Mhm.
start right then and there. I felt very advocated for in that process during my intake. Doing intakes suck. They're just like an audition for a part that you really don't want, but you need. And it was really lovely. It wasn't like overly complicated. I didn't feel like somebody was coddling or taking slow steps towards me, because when I share that I have BPD, a lot of people in the medical field will all of a sudden kind of shift their way they're talking to me. Doctors mostly, but
Yeah.
others as well.
Lack of
Um,
training.
Lack of training. I currently am dealing with a nurse practitioner who continues to try and push the, "Oh, I must have bipolar" narrative, when he hasn't done any assessment with me that would be more thorough, and he's done like 2 questionnaires, and I'm like, "That will took 15 minutes." And I'm like, That's clinically inaccurate. I know that the test for BPD is at least an hour, of like an intense questionnaire that you and I have or whatever, so that's a
Mhm.
bummer. But I will say the only thing, and I said this to Dr. Linden as well, that would just add to the awesomeness, and this isn't really a lacking as much as it is just kind of a symptom of where we're at, is
Mhm.
some more male representation within the clinical field. Not
Mhm.
because I can't work with female or non-binary or non-gender conforming individuals, but I know that there are men, and I know that there are men who simply are unable to at this particular point. And
Mhm.
there were certain one-on-one sessions I had with my therapist that I withheld things, not because I thought that they would make me seem like dirty, gross, or ashamed, but because I just didn't know how to talk about it with someone who wasn't a
Mhm.
man. And with my content and what I do online with social media, I mean, that is kind of the bent I go, not exclusively, because of course we are all part of the dialectical world and there are more than two genders out there. So there's plenty of things to work with. In my limited experience, the guys who I see who need the most help tend to shy away from the help they need because they're a little sexist. And
Mhm.
if we could just get them in the door, I think they'd be pleasantly surprised that, there's so many other things to bring to the table than their sexist door frame. I
Absolutely.
Yeah,
Mhm.
but again, that's not like a lacking thing. That really is more of just like this would make it even better, because I
We
still
are a
think,
female-dominated team. We have had male clinicians, come through our doors. We currently have one male clinician, wonderful Joshua. And there are, I guess, challenges that come with that. A lot of our female clients don't want to work with a male clinician
yeah,
and do struggle to connect with it and to feel safe with a male clinician. And we can understand that. And well, the male clinicians I've worked with at DBTOC are wonderful and are, so amazing and want to be this different person for, a different representation of
yeah,
the male individual. So I hope so too. I hope that is something that is the trajectory, which is interesting because, in original psychologists out there and psychiatrists were all men,
I
and
know.
now primarily women, and hopefully then we swing back to the other side, right?
Yes,
Swung this way, and now
yes,
we're back to the
yes.
middle.
The pendulum can come back to the middle. Absolutely. Yeah. No, that's yeah. I had a very lovely experience. I also had like a really awesome group that I was into. Everybody asked a lot of questions. We were all very chatty, which made me feel a lot less self-conscious about asking questions myself. And it was very evident from the start that my two leaders were very along for the ride. Like I didn't feel like anybody was above me or talking down to me, because that can get very distracting very quickly when you feel like somebody is higher than thou, and it's hard to
Mhm.
listen to them when you think that they, even though they do know more, it's like, well, don't tell me.
One of our
um,
expert DBT consultants has shared for a group facilitator, we have to be, a teacher, we have to be an entertainer, like an actor, like a
yes,
comedian, like so many things. So we really do try to make groups fun, even though it's not always lighthearted information. But
yes,
you have to entertain the group. Like if a
yeah,
group isn't laughing at least once during, the group hour, hour and a half, 2 hours, then we've done something wrong.
yeah. No, and that was very much true to my experience. It was very lovely. Yeah, it was great, and it was great. Thank you. That was a great question. Do you have any others?
Not at this time.
Okay, this is not a one-off, by the way. If you guys have time, I will continue to knock on your door because this is just, to me, I think the most important way to get people to be interested is to just
Mm,
meet you, understand what you're doing, kind of like see behind the veil because there is still this kind of like weird shrouded misunderstanding of what DBT is. The most
mm,
recent example in the media that I saw was on the Marvel series She-Hulk. They're just like casually doing DBT for like 10 seconds and then like
yeah,
that's it. I was like, whoa, we just swam past that one.
yeah.
Okay, well then
Much
I
more intricate than that. We were excited to hear DBT, and there's so much more.
I know that was my thought exactly. I was like, oh cool, oh it's gone. Oh, okay, that was cool.
Mm.
All right, I'm going to ask you the heavy hitting last question, which is, what is a truth you wish people suffering from suicidal ideation, mood swings, depression, self harm could internalize and believe immediately with the wave of a magical wand?
I've thought about this, and I've, clients who I hope this is true, um, for right now, who I'm working with. But I think of what Dr. Marshall Linehan says about radical acceptance, that life can be worth living even with suffering,
Mm,
even with the pain and suffering that we all encounter. And that's really hard to believe
yeah.
in the beginnings of treatment. I think almost at any time that life can be worth living, even with that pain and suffering. We all do experience pain and suffering, and it is very painful, very difficult, very hard. So that's why we need the validation, the understanding, the sensitivity, and it can be worth living despite anything that you're going through. And you're not alone, and you'll get there. Reach out to your support, utilize your resources, don't make decisions in emotion mind, right? And come back to that. Mhm.
Awesome. Amazing. Amazing. Thank you, Nora, so much for your time and just for your candor and your willingness. This has been wonderful, and I look forward to future and further conversations. I wish you the best of luck with your continued success at the DBT Center of Orange County. And who knows, maybe next time we speak, I will have some like yoga poses I can ask you about because as of right now, I don't know any of them, but we'll know them later. But anyway, thank you so much, Nora. Bye, everybody. Thank you for watching.
Thank you.